Welcome back to the deep dive. We are really glad you're joining us today because we've got a fascinating topic lined up.
Yeah, we are looking at a really dense, highly concentrated stack of clinical medical notes today.
Right, and it covers basically everything a medical practitioner needs to know about a myocardial infarction.
Which is, what most of us just call a heart attack.
Exactly. So our mission today for this deep dive is to decode this really dense clinical shorthand into, well, a real-world survival guide.
Yeah, we're going to see exactly how medical professionals detect, score, and treat a heart attack, while the clock is just relentlessly ticking down.
Okay, let's unpack this, because before we look at the emergency room logistics, we kind of have to establish the biological foundation of the crisis, right?
Right, we have to define what an MI actually is at a cellular level.
So fundamentally, it's myocardial cell death caused by ischemia. I mean, essentially a lack of blood supply.
Yeah, the coronary blood supply gets compromised, the tissue starves, and, well, the cells rupture.
And clinicians confirm that this process is actually happening by looking for a rise in the troponin biomarker, right?
Exactly. But it has to be paired with clinical symptoms
Yeah.
or ECG evolution or imaging evidence. It's a multi-layered criteria.
Which makes sense. I mean, a solitary lab abnormality or just some vague chest pain isn't enough to pull the trigger on high-risk interventions.
No, definitely not.
Yeah.
You need the biological evidence of necrosis, which is that troponin leak corroborated by the electrical footprint on the monitor.
Right, or the patient's actual physical presentation. But that presentation, that's where our first major clinical hurdle pops up.
Oh, absolutely. Because before we can treat an MI, we really have to recognize it. And the notes reveal it doesn't always look the way we expect.
Yeah, so let's talk about the two phases of a heart attack. We have the classic one, which I like to call the Hollywood heart attack.
A Hollywood heart attack. I like that.
Right, because it's dramatic. It's that severe, crushing, pressure-like chest pain lasting over 20 minutes.
Yeah, clutching the chest, the pain radiating down the left arm or into the jaw or neck.
And there's sweating, nausea, shortness of breath, and that profound sense of doom.
Yeah, anger enemy. That sense of doom is actually a direct physiological response.
Oh, really? It's not just panic.
No, not at all. When a vital organ starts failing, your body dumps a massive catecholamine surge into the bloodstream.
Oh, wow. So it's a literal physical alarm bell ringing.
Exactly. Their neurochemistry is screaming that survival is actively being threatened.
But then we have the exact opposite end of the spectrum, the ninja heart attack.
The silent MI.
Right? This one completely bypasses all that dramatic chest pain. The patient just presents with extreme fatigue or they, suddenly tip into acute heart failure.
Yeah, and it's especially common in specific populations. The notes highlight diabetics, elderly women, and post-transplant patients.
So how dangerous is it when a major cardiac event disguises itself as just like being really tired?
It's incredibly dangerous. I mean, think about the underlying pathology for a diabetic patient. Long-term diabetes causes progressive neuropathy.
Oh, so nerve damage.
Right. The somatic nerves that would normally carry that crushing, localized ischemic pain signal back to the brain, they're damaged.
So the heart is dying, but the physical fire alarm wire has literally been cut.
Exactly. And in post-transplant patients, it's literal. The cardiac nerves were physically severed during surgery. They just don't have the pathways to feel the pain.
That is terrifying. It gives this false sense of security.
It does. Which is why doctors have to be hypervigilant with these at-risk populations. If they aren't, they could easily miss a silent MI.
Because you can't trust the patient's pain receptors. You have to bypass them entirely and look directly at the biological crime scene.
Right, you need objective tools to see the invisible damage happening inside the heart muscle.
Which brings us to the ECG and the biomarkers. Let's start with the ECG. It's a map of the heart's electrical activity, right?
Yeah, but an MI isn't just a static snapshot. It's a dynamic evolution over time.
Right, let's walk through that timeline. Because in the first few minutes of a totally blocked artery, you see these hyperacute T waves.
Yeah, they get incredibly tall and peaked. It's like the electrical system is hyperpolarizing in distress.
And then, within hours, that progresses into ST elevation, the classic STEMI pattern.
Right, and that ST elevation tells you it's a full-thickness transmural injury. The necrosis is spanning the entire wall of the ventricle.
Wow. And then, as hours turn into days, you get pathological Q waves. The notes say they have to be at least 40 milliseconds wide and 25% of the R wave amplitude.
Exactly. And eventually, the T waves invert. but those deep Q waves persist as a permanent scar.
We're definitely going to come back to that scar concept later. But let's shift to the blood evidence, the biomarkers.
Yeah, the chemical debris left in the bloodstream.
Right. So first we have troponin I, or T. It starts rising 3 to 6 hours after the ischemia starts, peaks at around 12 to 24 hours, and then, this is the crazy part, it stays elevated for up to 14 days.
Which is crucial, for patients who show up to the hospital late.
Yeah, like if someone endured a silent attack a week ago, the troponin is still there. It's like permanent DNA evidence left at the scene.
Exactly.
But then the notes bring up a second biomarker, CKMB.
Right.
And it peaks at the same time, 12 to 24 hours, but it normalizes super fast, like 48 to 72 hours.
It drops off very quickly, yeah.
So if troponin is this permanent DNA evidence that stays for 2 weeks, why do doctors even bother testing for CKMB? It seems kind of redundant.
What's fascinating here is that the rapid disappearance of CKMB is exactly what makes it so valuable.
Really? How so?
Well, think about reinfarction. If a patient is recovering in the ICU 3 days after a massive heart attack,
Yeah.
and suddenly they crash.
Oh, I see. Is it the original damage failing, or do they just have a brand new heart attack?
Exactly. And troponin can't tell you that because it's still maxed out from the first attack.
Oh, wow. Yeah, it's like having a security camera that records a single blended exposure over 2 weeks. You can't separate today's damage from Tuesday's.
That is a perfect analogy. So CKMB is your resetting camera. Because it drops back to normal quickly, a sudden second spike tells you they are having a new attack.
That makes total sense.
Okay.
So once the ECG and the blood tests confirm the heart is under attack, the medical team has to calculate the threat level.
Right. They have to categorize the exact level of danger to prioritize care.
And the notes give us these 3 main risk stratification systems: the TMA score, the GRACE score, and the Killip class.
Yeah. And standardizing risk like this is what saves lives in a crisis.
It's just wild to me how structured this is. They take the sheer chaos of an emergency room and reduce it to cold, calculated math.
You have to, because human heuristics fail under pressure. A doctor might unconsciously downplay symptoms in a young patient, so you need algorithms to strip away that bias.
Right. So the TMI score uses 7 variables to grade risk from 0 to 7. Low, intermediate, the high.
Yeah, but the notes highlight the GRACE score as being more accurate than TMI.
Right, because it factors in things like age, heart rate, systolic blood pressure, creatinine, cardiac arrest, ST changes, and troponin.
The baseline creatinine is a great example of why it's better. Rising creatinine means the kidneys aren't getting blood because the heart's pump is failing so badly.
Which leads us right into the Killip classification, because that focuses purely on heart failure progression, right?
Exactly. Class 1 is no heart failure.
Simple enough. And class 2.
Class 2 is when you hear an S3 heart sound and there's mild pulmonary edema. The heart is failing to pump fluid forward effectively.
So fluid starts backing up because by class 3, the notes say it's acute pulmonary edema.
Yeah, the back pressure forces fluid into the lungs. The patient is literally drowning in their own fluid.
God, that's awful. And then class 4 is cardiogenic shock.
The most critical state, systemic collapse.
So these risk scores tell doctors exactly how bad the situation is. But the universal rule of treatment, regardless of the score, is speed.
Oh, absolutely. The notes literally say, time is muscle.
Time is muscle. Every minute that passes, more heart tissue dies.
Which brings us to the gold standard of treatment, primary PCI, percutaneous coronary intervention.
Right, the catheterization lab. And the goal here is door to balloon in under 90 minutes at a PCI-capable hospital.
Or under 120 minutes from the first medical contact with EMS.
That is an insane logistical timeline. To diagnose, transport, prep, thread a catheter, find the blockage, and inflate a balloon to crush the plaque, all in 90 minutes.
It requires staggering precision. But what happens if you're geographically isolated and can't make that window?
Right, if PCI isn't available, they shift to fibrinolysis, clot busters like TPA or streptokinase.
Yeah, but you only have a 12-hour window from symptom onset to use those.
And the contraindications are absolute. The notes are very clear. You cannot give these if the patient has a prior hemorrhagic stroke, active bleeding, or recent major surgery.
Because fibrinolytics don't just dissolve the clot in the heart. They circulate systemically and dissolve every clot in the body.
Oh, so if you just had surgery, it would literally dissolve the clots, keeping your surgical incisions closed.
Exactly. It would trigger catastrophic, life-threatening bleeding.
Wow. Okay, so alongside PCI or clot busters, we have adjunct therapies. Dual antiplatelet therapy, anticoagulation, high-intensity statins,
Yeah, the statins stabilize the inflammatory environment of the ruptured plaque.
and ACE inhibitors, which are crucial within 24 hours, especially for an anterior MI, or if the ejection fraction drops below 40%.
Right, to prevent the heart wall from thinning out and remodeling.
And to remember the core acute treatments, doctors use the Bonn mnemonic for STEMIS, BOMB.
Right, beta blocker, oxygen, morphine, and balloon, meaning the PCI.
So beta blockers reduce the heart rate and oxygen demand. Morphine is for pain, selectively. Balloon is reperfusion. But here's where it gets really interesting.
The oxygen.
Yes, the O in BMB. Because you only give oxygen if their blood oxygen, their SpO2, is definitively less than 90%.
Yeah, which really bucks the whole TV medical drama trope where everyone gets an oxygen mask immediately.
Exactly. You see it in every show. But why is it actually bad to give them oxygen?
Because giving high-flow oxygen to someone who isn't actually hypoxic triggers a paradoxical response. It causes severe coronary vasoconstriction.
Wait, so the arteries physically clamp down?
Yes, you're actively reducing blood flow to the very tissue you are trying to save. Plus, excess oxygen creates reactive oxygen species that make cellular damage worse when blood flow is finally restored.
That is just wild. It's a perfect example of why you can't just rely on intuition. You have to follow the empirical data.
And you also have to know when the standard protocols can become dangerous traps.
Which is the final section of our notes today. Clinical traps and the real-world test. Because a standard 12-lead ECG is just a 2D representation of a 3D organ, right?
Exactly. And certain infarcts hide in the blind spots of that 2D map.
Like the posterior MI. Since the leads are on the front of your chest, a heart attack on the back of the heart doesn't show standard ST elevation.
No, it projects a mirror image. You see ST depression in leads V1 through V3 and a tall R wave in V1.
So doctors have to actively think, oh, I need to check the posterior leads and physically move the leads to the patient's back, V7 through V9, to actually see the ST elevation.
Right. You have to look from the correct anatomical angle. But there's an even more dangerous trap.
The right ventricular infarct, the RV infarct, it's usually an inferior steme with ST elevation in lead V4R. And the notes have this massive bolded warning: avoid nitrates and diuretics.
This raises an important question. Why? Why would nitroglycerin, which is a standard drug used to relieve chest pain in basically every other heart attack, cause a disaster here?
Well, because the right ventricle operates under completely different rules when it's damaged.
Precisely. It's a thin-walled, low-pressure pump. When it suffers a massive injury, it just becomes a passive conduit. It loses its ability to pump.
So to push blood through the lungs and into the left side of the heart, it totally relies on preload, right? Just the sheer pressure of venous blood returning to the heart.
Exactly. And what does nitroglycerin do? It's a potent venodilator. It drastically expands your veins.
So all the blood pools in the periphery. The venous return drops.
And if you strip away the venous return from a passive, infarcted right ventricle, the pressure just drops to zero.
Oh my God. Blood stops moving through the lungs, the left ventricle runs dry, and their blood pressure catastrophically crashes.
You induce immediate cardiogenic shock just by giving a standard drug to the wrong anatomical type of MI.
That is terrifying. Knowing how to read those specific leads is literally a life-or-death skill.
It absolutely is.
In fact, the notes run through a clinical scenario, an MCQ walkthrough, to test exactly this.
Right. Let's look at that case.
So we have a 65-year-old man who arrives with a 2-hour history of crushing chest pain. His ECG shows ST elevation in leads 2, 3, and AVF, with reciprocal depression in I and AVL.
Okay, so mapping those leads, 2, 3, and AVF, look at the inferior wall of the heart.
So it's an inferior STEMI. But the real question is, what is the culprit artery?
Well, based on vascular anatomy, the right coronary artery, the RCA, supplies the inferior wall in about 85% of people.
Leaving the left circumflex for the other 15%. But the key is contrasting that with the left anterior descending artery, the LAD.
Right. If the LAD was blocked, you wouldn't see it in 2, 3, and AVF. You'd see massive ST elevation in the anterior leads, V1 through V4.
It's just amazing. You're tracing a wiggle on a screen directly back to a specific millimeter of ruptured plaque inside the chest cavity.
It really is diagnostic telemetry at its purest.
So what does this all mean? I feel like we've navigated the entire clinical life cycle of a heart attack today.
We really have, from the silent, sneaky symptoms to the electrical evolution on the ECG.
We looked at the kinetics of the blood biomarkers, the math behind risk scores, the logistics of the 90-minute door-to-balloon time, and those terrifying hemodynamic traps.
It really highlights the razor-thin margin of error in emergency cardiology.
Yeah, the protocols are dense because, well, the human body is unforgiving. I want to sincerely thank the listener who provided this incredible stack of medical notes.
It was an amazing deep dive.
It really was. But before we sign off, I know you had one final thought you wanted to share about the ECG timeline.
Yeah, I do. It goes back to those pathological cues we talked about. The notes mention that they persist as a permanent scar on the ECG.
Right.
I want you to really think about that. Even if a patient receives rapid PCI, survives the heart attack, recovers completely, and lives another 30 robust years,
Yeah.
every single heartbeat for the rest of their life will carry a tiny, permanent electrical shadow of that one 90-minute window where their heart was starving.
Oh, wow. It's like a literal fossilized memory of survival.
Exactly. Written permanently into the electrical code of their body. Just something to mull over the next time you feel your own pulse.